All right, guys, my name's Izzy. I'm part of the Caring Medical media team, and I just want to welcome you to today's webinar with Dr. Hauser. We are going to go over a lot of questions, so we appreciate you guys sending in everything, all the questions, all the case studies, everything that you guys have done to help us get this together. We really appreciate. We know you guys are going to have additional questions, so we understand that. We do recommend that you go to our Caring Medical website. We do have a frequently asked questions page. It can answer a lot of those questions that we may not get to today. But if you do have additional questions, we also can answer them in the office. So without further ado, I'm going to introduce you to the one and only Dr. Hauser. And here he is.
Hi, everybody. So much appreciate you guys. Thanks for spending a couple hours here. We're going to have a lot of fun tonight. And like I said last time, the people that I look up to are obviously my staff, my wife, who's been probably the biggest influence in my life, and my greatest teacher has always been the patient. So when I decided to do this a few months ago to have webinars, I just want to be a help. So if there's anything else that I can do or the staff here can do for you to help you get healthy, please let us know. So we're just trying to see if we can be a bigger help than just for the clients who come to see us here at Caring Medical. And I think most of you guys know, I try to love God. Jesus said, love the Lord your God with all your heart, mind, soul, and strength, and love other people in the manner in which you love yourself. So being a Christian, I want to just start us off with prayer. So dear God, we thank you for this time that I could spend with several hundred people around the globe here and help the words that I say and all the things that are shared, Lord, that your love might come across. I pray, Lord, for your healing power, even in the words that are spoken, and through your Spirit, Lord, that your healing power would go out and help people, Lord, to get hope, to get help, Lord, that the diseases they have and the questions that they have, Lord, that they would be healed and that you would be honored. So we love you. In Jesus' name I pray, amen. As you guys know, for the last 10 years, I've been writing a joint instability book, and what we're doing is releasing chapters. So if you guys would go to the website, you can get the latest chapter. This chapter is on osteoarthritis or joint gangrene. So I really encourage you, if you really want to dive deep into Hauser's Law number 1, which we'll talk about soon, please get that chapter. It's a great chapter about how ligamentous joint instability causes osteoarthritis. So we're going to answer a lot of your questions. All the questions, basically the answers, will relate to Hauser's laws. So I tried to put in 5 different scientific laws the structural cause of human disease. So the structural cause of human disease. And this is 4 of the Hauser's laws, and then we'll talk about the 5th Hauser's law. Hauser's law number 1 is, if the etiology of chronic pain or joint degeneration remains elusive, it can be traced back to ligamentous joint instability. So the structural cause of osteoarthritis is ligament injury, and the condition is called ligamentous joint instability. So this is an animal study, and it shows that as you stretch the ligament, eventually the ligament will rupture. So the anterior cruciate ligament is like 40 millimeters in length, and you could see that all it takes is at a certain point only 2 or 3 more millimeters of stretching, and then it completely tears. So when we talk about prolotherapy, we're just talking about tightening the ligament a half a millimeter, a millimeter, 2 millimeters. So you go from a competent ligament here to a complete tear in this animal study of just 3 millimeters. So when we're talking about the bones are moving too much, or joint instability, often it's just a couple of millimeters or 3 millimeters. So a millimeter is the width of a quarter. So that's an important point. So when the ligament becomes incompetent and the bones move too much, that's what causes the articular cartilage to degenerate, the disc to degenerate, cause meniscal tear, tendon tears, stuff like that. So this is basically, it's a progressive disorder too. Like you guys know that when a screw is loose on a hinge, like a cabinet door, and you keep using that door, the next screw is going to get loose because the initial screw that's loose can't handle the force, so the force goes to the next screw. Well, ligaments are the same. So in the knee joint, you have the medial collateral, lateral collateral, anterior, posterior cruciate ligament. So it starts out with one ligament injury, which normally is in the inside of the knee. Then the person's walking around, the bones are moving too much. Then eventually the next ligaments get injured. And then eventually the joint gets unstable. And then you get like meniscal tears, cartilage gets worn out. And the treatment, of course, for a loose screw is what? You have to get a screwdriver. That's the only thing that's going to cure it. Well, the best treatment to tighten a ligament, to stimulate the repair of a ligament, is prolotherapy. Prolotherapy is an injection technique that stimulates the repair of ligaments, tendons. It basically stimulates the repair of the white structures of the joint. We all know that when you eat a steak, the steak is red because it has a really good blood supply, and steak is the muscle. So muscle injuries, you don't do anything, you heat it, you ice it, they basically almost always repair. But the white structures of the joint, the cartilage is white, meniscus is white, the labrum's white, ligaments are white, tendons are white. Those things have a poor blood supply. That's why they're white. So if you injure those structures, you have to go in there often to stimulate them directly with various proliferants. That's where we get the word prolotherapy. Prolotherapy is proliferative therapy. And the most common proliferant that's used, that's natural, is D-glucose or dextrose and platelet-rich plasma. And you guys probably know, you take out the blood, you spin the blood down. The platelets have the growth factor. So those are the two most common proliferants used in prolotherapy around the globe. Hauser's law number 2 is that if you have a chronic symptom and no one has figured out the cause of it, if you follow the neurology will lead to ligamentous joint instability. So for instance, you have sciatica, you have pain down your leg, they can't figure out the cause. If you follow the sciatic nerve is basically made up of the L5, S1 nerve roots. So then the person likely is going to have ligamentous lumbar sacral instability. Now, if a person has a digestive problem, right, you have a digestive problem. So basically, Hauser's law number 2 would say that you have, my stomach gets bloated, I feel nausea, I can't digest my food good. Well, then if you follow the neurology, so what's the neurology of the stomach? The stomach is innervated by the vagus. The vagus nerve to the stomach causes contractility. It also causes hydrochloric acid to be made. Okay, so Hauser's law number 2 is I have upset stomach. If I follow the neurology will lead to ligamentous joint instability. So it means that if you follow the vagus nerve runs right in front of the anterior cervical vertebrae. So you have to look for ligamentous cervical instability. And you've heard me say it's ligamentous joint instability requires usually that the x-ray or the scan, it has to be a motion scan. Because if you just lay down, or if I put a cabinet and I lay it down, you don't know if the hinge is loose or not. Like, you have to move the hinge. So this is what it looks like when you have a flexion extension x-ray. Obviously in the office here, we do digital motion x-ray. So it just means that somebody could tell me, I'm just telling you, doc, I only get dizzy when I go like this. Like I turn my head and then all of a sudden I get floaters, I get dizzy, I get blurry vision. Well, we would have the person move in that manner or hold this position and then do all the scanning in that position. So in other words, when a person moves, the vertebrae are supposed to stay together. Like they're not supposed to go like this. So you could see like right here, the person's flexing and then all of a sudden there's a separation. So this person had a 2.9 millimeter instability, 2.5, 1.9. And you might say, whoop-de-doo, what's 1 or 2 millimeters? But the point is your spinal cord only has about 2 millimeters of extra space in the canal. So, and then when the person bends down and they have ligaments that aren't holding the bones together and the vertebrae shifts, the muscles clamp down to stop that motion, because if the muscles didn't stop that motion, the spinal cord could get hit. The spinal cord could get hit. So when the ligament gets stretched out too much, it causes, through the ligament muscular reflex, it causes the muscles to tighten. So if you have chronic muscle tightness anywhere in your body, it's most likely underneath that you have ligamentous joint instability. And the way to document it is you have to do like flexion, extension, x-rays or MRIs, but real motion is better. So real motion is fluoroscopy. So digital motion x-ray is fluoroscopy. And then in the United States, we now have dynamic digital radiography, which is motion x-ray. So in other words, it's basically the same thing where it's going like this, but instead of 30 pictures per second, it's taken 5 pictures per second, but it still looks like a movie camera. And then this is where you see the vagus nerve. The ganglion of the vagus nerve runs right by the atlas. So throughout this, we're going to talk a lot about the atlas, The thing is, the most important bone in the human body, the most important bone, in my opinion, of the human body is the atlas, because your head sits on the atlas. And the atlas rotates. That's how we can move our heads very quickly. So the atlas is already very mobile, and when you get instability, like you get hit on the head or you look at your cell phones too much, right? You look, we all get addicted to the cell phones. So the problem is if you hour after hour after hour look down at your cell phone, so we call that the forward head face down lifestyle, or a person's working on the computer like this, the ligaments are going to all get stretched out in the back of the neck, and you're going to end up with multi-level ligamentous cervical instability. And then once you have instability, the treatment is either you're going to end up with a cervical fusion or you're going to have to get a bunch of prolotherapy. Now, having said that, you can improve the symptoms by getting a curve. So one of the things that all of us need is to know what our cervical curve's doing. So everybody anywhere in the world can get a lateral C-spine x-ray, and the normal curve is supposed to be like this. So the normal curve is supposed to be like this, lordotic. It's called lordotic. So when you lose the lordotic curve and the vertebrae go forward because a person's bent down all the time. So imagine what structures are right here, 1 to 2 inches, 5 centimeters in front here. So when you lose the cervical curve, the vagus nerve gets stretched and compressed, and you get vagus nerve degeneration. So in other words, all the organs that are innervated by the vagus nerve could degenerate basically. And then you start blocking your jugular veins even when you go to bed. So the problem is, if your jugular veins are blocked when you go to bed, when you go sleeping, the brain pressure starts rising because the ports where the fluid goes out of the brain are blocked. And then that fluid then can go around your eye nerve and give you blurry vision. It can go into the balance nerve, which is called the vestibular cochlear nerve. Then you get spinning, you get vertigo. And then of course, if the waste products can't get out of the brain, guess what that's going to cause? Brain fog, cognitive decline, and ultimately it could lead to Alzheimer's or dementia. So if you have cognitive decline, it's most likely that you have intracranial hypertension from the jugular veins getting compressed. So in other words, person's on the computer, cell phone, and ultimately you get ligament injury, the capsular ligaments. If you've never read Danielle Steilen, my associate, and me, we wrote an article in 2014 on capsular ligament injury, cervical capsular ligament injury, ligamentous cervical instability. Please read that article. Great article. And then ultimately, you're going to get with that, you're going to get where the vagus nerve gets injured. And when the vagus nerve get injured, you can get leaky lung, you can get asthma, you can get tachycardia or POTS, you can get liver disease, poor digestion, leaky gut, inflammatory bowel disease, glomerulonephritis, autoimmune disease, gastroparesis, immune dysregulation, and a host of other symptoms. Now, if you look at in the back of your throat and you go, ah, your palate is supposed to rise. If you go, ah, and the palate doesn't rise, you probably have bilateral vagus nerve injury because the levator veli palatini muscle that raises your palate isn't getting the nerve supply. So this particular person, see how the palate here is lower on this side than this side? So they have right vagus nerve injury, and likely this person, because the right vagus nerve innervates the digestive tract, and the left one does too a little bit, but primarily it's the right one is the digestive tract. The left vagus nerve innervates the heart. I mean, the right one does too, but it's primarily the left one. Like when someone has atrial fibrillation or they have terrible tachycardia, like all of a sudden their pulse can go from 80 to 130. It's normally in our office when we test them, they have degeneration of their left vagus nerve. And you can see where the uvula is deviated here. And then if you want to know, like, is the vagus doing good, you could take a tongue blade or something in the back of the throat, and you're supposed to have a gag reflex. Like when you take a tongue blade in the back of the throat, you should be choking. And if you go back there and it doesn't do anything, you have an absent gag reflex. And that's another sign of vagus nerve degeneration. Hauser's law number 3 is the cause of most chronic disabling symptoms of human diseases when the etiology remains elusive is by dynamic carotid sheath compression from ligamentous cervical instability. So you guys know this, I've said this a lot of times, but the carotid artery is in the carotid sheath along with the internal jugular vein, the vagus nerve, the glossopharyngeal nerve, and the spinal accessory nerve. So on ultrasound, right, you can get an ultrasound anywhere in the world. When you do an ultrasound, you can't just do ultrasounds here because often here the carotid sheath is fine. The carotid sheath is going to get blocked where? Where is the tension going to be? It's going to be by the forward atlas. So you have to look at the carotid sheath up here. And when you look at it up here, it's very constricted. And this just shows you, this is what the jugular vein is supposed to look like when you're going to sleep. It's supposed to be totally open. But what we find is people are more like this. So basically the jugular vein, instead of being 10 by 10, when we test people they have headaches, they have migraines, they have dizziness, they have blurry vision, they have tachycardia, the stomach's not working, they might even have body pain because the vagus nerve is all degenerated. It's like this because their curve is so bad. And then, of course, when they turn, the vertebrae moves too much, and that's where you can get blocks of the cerebral spinal fluid and get artery compression, and that can give you drop attacks, vertigo, and a host of other symptoms. I put this on here just to show you how close the jugular vein is to your hearing nerve. The jugular vein is right next to where you hear, like the cochlear nerve, the vestibulocochlear nerve. You are not supposed to hear venous flow. When you have jugular vein compression, guess what happens? The flow through the jugular vein goes from a low pressure system to a high pressure system. Once it gets to be a high pressure system, that's when you get tinnitus. So if you have tinnitus, it's likely you have blockage of the jugular vein right at the atlas. And when you have pulsatile tinnitus, the carotid artery and the jugular vein are not supposed to touch. So when we do ultrasounds, we see them touching. They normally touch right at C3, C4. So C3, C4 is another area where, especially with flexion, the people have instability. So the treatment of it is you got to get a good curve and you got to get stabilization by prolotherapy. Now, if you don't have access to ultrasound, then of course you could get a CT venogram. You have to get a CT venogram of the neck and the brain, and then the CT venogram would normally show that the carotid artery and the jugular vein are hitting around here, and that's what's causing the pulsatile tinnitus. Like you're actually, because this is touching this, the pulsations of the heart then are heard by the vestibulocochlear nerve. And then if you've been diagnosed with Meniere's disease, or you have dizziness, or you have Melde-Barkman syndrome, like you always feel like you're on a boat or things are moving, then you probably have jugular vein compression here right at the atlas, and the fluid is building up and it's screwing up your vestibular nerve. That's called vestibulopathy. So if you've been diagnosed with vestibulopathy, semicircular canal dehiscence, dizziness of unknown origin, it's likely that you have jugular vein compression. Yeah, and then ultimately what happens is toxins can't get out of the brain, so you get a polluted brain. You feel dumber and dumber as the days go on. You can't do your work. So these are all symptoms of jugular vein compression and obviously cognitive decline. And if the pressure and the waste products don't come out, then of course you're going to end up getting Alzheimer's or dementia. Hauser's law number 4. If the etiology of a chronic disabling symptom or disease is not found using Hauser's law number 1 to 3, the cause will be an alternative fluid flow obstruction, right? So this was Jamie. Jamie had dystonic storms, like she would be writhing, then she couldn't breathe. So we recently had another patient with dystonic storms that we diagnosed in the office. So basically, this is called a transcranial Doppler. So we did a transcranial Doppler test. Her blood supply to a certain part of her brain stopped. This is what this is right here. Then 8 to 10 seconds after, like she held a certain position. So we had her holding certain positions. And in one position, her blood supply stopped to a certain part of her brain. And then all of a sudden, so we documented for her that she wasn't crazy. And this is what, you are not crazy. Like the thing is, the average doctor just doesn't understand ligamentous joint instability. So it's common in our office for people to have been told that they're crazy. It's psychological. And I'm just telling you, when you have jugular vein compression or you have an artery that's getting blocked, I mean, you can get any symptom. You can get, like, people will say, well, I have these episodes. So I had one patient, the patient would turn their head and then all of a sudden they go 111111111. Or we had another patient who we would hold them in a certain position and all of a sudden they would blank out. Like they were still breathing and everything, but they were totally out of it. And they were diagnosed with psychological non-epileptic seizures. Well, it's not psychological, it's a structural thing. They had ligamentous cervical instability causing a cerebral spinal fluid block or arterial block leading to the seizures. So ligamentous cervical instability can cause whiplash-associated disorder, vagus nerve dysfunction, drop attacks, syncope, headaches, dizziness, migraines, gastroparesis, and a host of other things. So ligamentous cervical instability can cause compression of the carotid sheath, other fluid flow obstructions, drop attacks, a host of other symptoms. So the question is always, well, what do I do about it? Well, anyone can get a lateral C-spine X-ray. So if you get a lateral C-spine X-ray and you're like, oh my gosh, I never realized I don't have a C curve, I actually have a reversal of the curve. So the easiest way to stop that is for your computer. If you work on the computer, you got to elevate the computer. And the elevating the computer, the two danger motions that most people that are very bad for people to do are flexion, looking down at a cell phone, or if your chin is forward. So those are the two things that I would tell people. You got to minimize them. And if you're somebody who has brain fog or you're struggling with problem solving and you know that your cognitive ability, your problem solving ability is going down, you have got to significantly reduce your screen time. So that would be that, like, in other words, when you're sick and you're going to get the flu, you have to be in bed and rest. So my advice usually is for the patients that come here, when they have brain issues, I tell them you should lay down in the bed on a certain side that causes the jugular veins to be open more, 5 minutes every hour or every 2 hours. So if that's you, you have to take breaks. Like, in other words, when you have a bad curve or you have ligamentous cervical instability, the brain pressure is too high. So you've got to lay down and you have to induce the cervical curve. So you induce the cervical curve by laying on a cutout pillow, like that's one way to induce a cervical curve, or you lay on your side with your head extended. Now, if you're somebody who has neck pain and it's primarily on the right side, usually you do better if you try to lay on your right side with your neck extended. Or if you're somebody who always gets migraine headaches on the left side, you need to lay on your left side with your head extended. And especially if you feel like a bad symptom's coming on. Like if you have a symptom that's primarily on the left side, you usually have to lay on your left side with your head extended. And then these are a lot of the things, like we've had patients, they elevate their screen, they do prism glasses, there's different things that you can use to keep the cell phone up, physical therapy, lay on a Denerol. This is Izzy, you saw her earlier. Different weight systems that can induce. This is the pillow that I have, the Denerol pillow. That's me after a hard day working or doing a webinar for 2 hours. And then prolotherapy, this is a degenerated ligament. This is what it looks like. See how right here there's a lot of cells, the black are cells. So when we say degeneration of the cartilage, degeneration of the ligament, it means that there's a deficiency of fibroblasts or cells. So prolotherapy injections cause a massive influx of fibroblasts into the area. The fibroblasts are what make the ligaments stronger. Ligaments are supposed to be like rope. They're not supposed to be like strings, right? So when you have clicking of a joint, clicking of your neck, clicking of your shoulder, these are all signs of ligamentous joint instability or the ligaments are damaged. Prolotherapy causes a tightening of thickening of the ligaments. Prolotherapy normally is given about once a month. Ligaments heal over a 4 to 6 week period. You break a bone, doesn't the doctor say that you have to wear the cast for 4 to 6 weeks? So, and then most people, most joints of the body are about 4 or 5 visits. Obviously, upper cervical instability, that's the one that usually takes longer. So when people come into the office here, Danielle or I would tell them about how many visits we thought it was going to take to get them well. So the goal is you got ligamentosis, degenerated ligament. Prolotherapy causes an influx of cells that causes fibroblastic proliferation. That's where you get the word prolotherapy. And then you get a normal ligament. And that's the C1, C2 area. Prolotherapy injections are done into the capsular ligaments and the other ligaments in the back of the neck. Hauser's law number 5. Give you an example. This was this week. I had a young lady come in, had a lot of different symptoms. She had hypermobility, EDS, and you could tell like she was happily married and everything. And I asked her, did she have any kids? And she said, honestly, doc, we've tried to get pregnant. I've lost several pregnancies. She said, I lost several pregnancies. I can't carry the pregnancies. So then I told her about Hauser's law number 5. So Hauser's law number 5 is if a chronic disabling symptom cannot be explained by nerve issues or fluid flow problems, the cause is likely dysfunction in the organ's connective tissues, right? So if we look here, this is the pelvis, right? This is the pelvis. That's the sacrum. This is the pubic symphysis. Well, look at this. Isn't this very interesting? You have the rectum, you have the cervix, which is the uterus, and you have the bladder. Isn't it interesting of how these organs have ligaments that connect to bones? So in other words, if you have hypermobility EDS or you have pelvic instability and you get pregnant, like in this person, and the uterus is going bing, 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 because you have loose ligaments all over, don't you think it may be harder to carry the pregnancy? So if you've had chronic prostatitis, they've diagnosed you with pelvic floor dysfunction, you have a rectal problem, you have a defecation problem or something, nobody can figure it out. You have cystitis, you have interstitial cystitis. So cervix problem, menstrual problem, carrying pregnancy, polycystic ovarian disease, these all can have a ligamentous joint instability problem. So in our office, what we would do is, again, we would do motion x-rays of the pelvis, and then under ultrasound, we would measure how wide is the pubic symphysis. Normal pubic symphysis should only be 3 millimeters or less. And then they found in scientific studies that every time a woman gets pregnant, it increases. So at some point, it's going to be incompetent. And then the treatment that I recommended for this young lady, well, first of all, I referred her to Danielle because in our office, she's the one that sees the pelvic patients. So if she did get pregnant, we would have her be using a pelvic support. And even before pregnancy, if she had pelvic instability, we would do prolotherapy. And then once she got pregnant, we would have her do a pelvic support, and she'd have a much more likely to carry the pregnancy. So these are all questions that you guys asked. I'm just going to bullet point them. Why do prolotherapy treatments vary from 1 or 2 injections at a site to many? I would definitely say that people need many, many shots to recover from ligamentous joint instability. Ligaments are a mesh. So if somebody had pelvic instability, and this is the sacroiliac joints, and this is the ligament mesh, do you think like 1 or 2 shots in this mesh is going to tighten it up? Like this might be, 12 shots here, 12 shots here. So it's like spot welding. I mean, I just don't think spending a lot of money for 1 or 2 shots of prolotherapy is worth it. In other words, when you have ligament incompetence, it's likely the whole thing is degenerated. So in our office, we call it comprehensive prolotherapy. So we would do lots of shots. Can bone spurs in the hip be overcome with treatment and stabilization of the joint? How effective is prolotherapy as an alternative to knee replacement? So in our office, the better, like in other words, if we have a non-painful hip or knee and a painful hip or knee, if the range of motion of the painful knee is pretty much similar to the non-painful knee, prolotherapy almost universally is going to be effective. So in other words, if you have a hip joint and the painful hip and the non-painful hip is about the same range of motion, it's almost assuredly prolotherapy is going to work. If the person comes in and they're walking and they can't move the hip at all, and the bone spurs are horrible, yeah, you need a hip replacement. Like sometimes people will say, no, I want to try prolotherapy. Yeah, but if your hip joint, the ball is now square on one side, like it's not even a ball anymore, you have to get a new ball in there. So those are kind of some good guidelines. What are your thoughts on grounding pads? All this stuff like infrared, grounding pads, definitely very, very good, very, very healthy, right? Marion and I, Izzy, we live, in Southwest Florida, beaches everywhere. We all know, when you're walking on the beach, immediately you feel better, right? Like your feet are in the sand, like we just call it sand therapy. Like, when you're grounded to the earth, it's definitely helpful. So definitely is helpful. Are there any other ways to strengthen, heal upper cervical instability, vagus nerve dysfunction, degeneration, ligaments than prolotherapy? Yes, like obviously I said obviously if somebody has horrible ligamentous cervical instability, you got to get a fusion or you got to get prolotherapy. But if you can do exercises, posture to get a good neck curve, that's going to reduce the tension on the vagus nerve. And we all know there's 20, 50 different things that we can do to strengthen our vagus nerves, right? The vagus nerve is strengthened by slow exhalation through your nose. So if we all breathe 6 times a minute instead of 16, 5 seconds in, 5 seconds out, real slow, deep breathing, that's going to help. I think probably the best thing, one of the best things for the vagus nerve is just laughing. And anybody who knows me, lots and lots of laughing. I probably laugh 80 to 100 times every day, right? And I often say, I'm 62 and my testosterone level is like 912 and I don't take any hormones. So Dr. Hauser, you know, your friend has a testosterone level of 912, but a lot of it's because I just don't carry around fear. I just am who I am, right? I got crazy glasses on. I want to wear the crazy glasses, right? So I can't worry about, oh, you're supposed to be a professional and you got to look a certain way. Like you just got to be yourself. And then kids laugh and laugh and laugh and laugh. So we got to, like Jesus said, unless you're like a little child, you're not going to have any inheritance in the kingdom of heaven, right? So we got to get back to like, get the weight off of us. Don't watch things that are complaining and grumbling. Be around really positive people. Watch funny shows. Try to laugh a lot more. And I know a lot of you guys are struggling with your health, and obviously I'm trying to be a help. And if there's anything else we can do, you just let me know. So get a good neck curve, have a pro Vegas lifestyle, uh, and obviously the more you can increase the blood circulation to a ligament or a tendon by what? Infrared helps, hyperbaric oxygen helps, magnets help. Like Dr. Phil Pott, he has on his site, he has really high powered magnets. So all those things help. And then obviously, if that doesn't resolve the symptoms satisfactory, then of course consider getting prolotherapy. Okay, now obviously, ligamentous cervical instability means that the vertebrae are moving too much. So if the vertebrae move too much, that can cause a tear in the dura, which leads to cerebral spinal fluid leaks. I think this is just me talking. I think cerebral spinal fluid leaks are very, very rare. I just think they are. People come in to see me. I order every single test to find a CSF leak. I found basically zero in my whole career. And I've ordered all kinds of tests and da da da. What we do, I mean, I've obviously had people with CSF leaks. So what I do is I put blood in the prolotherapy solution and I inject a bunch of blood. Of course, we've had people that we've done blood patches and everything, but I think that the way we test it is normally people's optic nerve sheath diameter is very high. So like when you have a jugular vein compression, fluid accumulates around the eye nerve. So when we look at, is there fluid around people's optic nerve or eye nerve, it's very high. Occasionally we'll get somebody who they feel spectacular laying down, horrible headaches when they sit up, and their optic nerve sheath diameter is very, very small. So that means that, and if they have an internal jugular vein block, the optic nerve sheath should be high. So if it's low, that would mean the cerebral spinal fluid is low, then they probably have a leak. So the way we would treat it is, again, we would do prolotherapy uh, with uh, with blood in it, like whole blood in it. Most of the people that have had suspicions of CSF leak, by the time I see them, they've already had blood patches. So, okay. How would this affect? So it doesn't really affect the treatment I do. I just would add blood. Can a patient have a CSF leak in the absence of intracranial instability? Yes. Should I request a neural quant? Uh, NeuroQuant is just another test that can show which part of the brain is affected. It's helpful, but I don't need it to treat somebody. Would it be necessary to get a CSF leak resolved first before coming to your clinic? It actually wouldn't. It actually wouldn't, because a lot of times the cause of the CSF leak is ligamentous cervical instability, which is the reason why somebody would need to come here. Does it help to add vitamins to the prolotherapy solution? What else do you put in the mix? So normally we use dextrose D-glucose. So when you sprain your ankle, the sugar inside the cells, the D-glucose, which is not sucrose or table sugar, the normal sugar in the body is D-glucose or dextrose. So when you sprain your ankle, the cells release D-glucose. That D-glucose then is a stimulus for the platelets, the stem cells, and all the things to come to the area. So we use D-glucose. Then we often use a substance called a sclera. You can use certain vitamins, minerals, manganese, this or that. And then, of course, you can use platelet-rich plasma, which is a component of the blood. Our biooxidative therapy, so no, back in the 90s, I did a lot of ozone and biooxidative therapies. They're obviously helpful. Prolozone does help some people. If you have ligamentous joint instability, in my opinion, it doesn't resolve that. The prolozone, when you have a stable knee that's painful, like you have osteoarthritis, the knee's real stiff, and then you do prolozone, it works really good. But if you have where the joint is going wah, 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 like there's so much instability, you're going to have to do some more stronger proliferants, like platelet-rich plasma. Peptides do help people, but by the time I see them, they've already tried a lot of that stuff and it hasn't worked. How far apart are treatments? Ligaments heal over a 4 to 6 week period, so we normally see them every 4 to 6 weeks. How do you know which patients are optimal candidates for treatment? Well, if somebody has clicking, cracking of a joint, that would be one positive that they have ligamentous cervical instability or ligamentous joint instability. Do they have pain? Like, in other words, they have clicking, popping in their shoulder, clicking, popping in their neck, and then they have neck stiffness, right? Well, those are all signs of joint instability. Joint instability responds really good to prolotherapy. Then if you have a symptom that's worse with you being upright and better when you're laying down, that's another sign of ligamentous cervical instability. How do you decide who is accepted? So, we just want to, when we screen people of who should come to Caring Medical, we just want to make sure that you have a ligamentous joint instability that's likely causing the problem, and those are generally the people that we can help. What's the difference between a prolotherapist and a pain specialist? Well, there are some pain specialists that do prolotherapy. A prolotherapist specializes in prolotherapy or ligamentous joint instability. As you know, a pain specialist, they'll do steroid shots, they'll do radio frequency of the nerves. They're normally not a specialist in ligamentous joint instability. And by Hauser's laws, I've shown you that there's so many medical conditions that the underlying cause is ligamentous, lumbosacral instability, shoulder instability. If you have a chronic symptom and you've went to 25 people, 100 people, it's likely you have ligamentous joint instability because you never saw a prolotherapist. So that, like, the other day I saw 5 new patients, right? And each of those patients probably saw over the course of the 10 years, like, it's common for me to see people and I'll say, like, I had a 20-year-old and I said, well, when was the last time you felt good? And she said, Doc, my whole life I haven't felt good. My whole life I haven't felt good. Because you can have ligamentous joint instability since you were born, right? When they twist your neck, you had a C-section, they use forceps, you can have ligamentous joint instability basically your whole life. I've had a failed Botox injection. I've been in speech therapy. I wanted a procedure to restore my voice and breath better. What might I qualify for? So there's some other slides. Okay, I didn't know if it was here. So I have some slides that show the recurrent laryngeal nerve that innervates the voice box or the vocal cords, and that's a branch of the vagus nerve. So this patient likely has a vagus nerve degeneration from ligamentous cervical instability. So I'd recommend getting an X-ray. Obviously, it'd be better if you got a digital motion X-ray, and most likely there's going to be ligamentous cervical instability causing vagus nerve degeneration. So if you resolve the stretch and compression on the vagus nerve, the voice will usually come back and the breathing gets better. It's very common that we see singers, we see singers who can't sing anymore, and then we treat them and then they get their singing voice back. What are some suggestions for managing my symptoms? Pain at the base of my head and down into my shoulders, rapid heart rate anxiety. Rapid heart rate, again, is normally from vagus nerve degeneration. So again, a pro-vagus lifestyle. Get your cervical curve good. And pain at the base of the head. If you have pain at the base of the head, that's normally what? It's normally that you have atlas instability. So atlas instability. So a person with atlas instability normally needs prolotherapy or an upper cervical fusion, though some people get a lot of benefit from upper cervical chiropractic care. And obviously, if a person has a bad curve, the atlas is going to be much more likely to be unstable. If you get a good curve and the atlas is flat and your head sits on it, the ligaments don't have to be as tight. So probably the best thing the person can do is really, really restore the cervical curve. I made my joint cartilage and arthritis worse by taking ibuprofen for 10 years. Now that I've stopped, can my joints heal? Absolutely. Absolutely. I mean, there are times where you got to go to a doctor to do prolotherapy or platelet-rich plasma. I've seen people in their 90s get their knee arthritis or hip arthritis better where they can walk really, really good. I have been treated by Caring Medical for 10 years. What advice can you give me to stay well and optimistic and not to have to continue with these issues in the future? It's get in shape, get in shape. The stronger your muscles are, the less strong the ligaments have to be. So all of us have to move. We have to try to maintain our muscle mass even as we get older. So Marion, my wife's a very good exerciser. She has a gym. I enjoy biking, swimming, running. She loves lifting weights, but you got to do something to maintain your muscle mass. And I would say if you're able to, have a standing desk, So I have a standing desk. So you're standing. I don't know how many steps I have all day, but I stand most of the day. Then Mary and I live about 5 to 6 miles from the office, so there definitely are times where we cycle into work. Like try to get activity. I see Izzy. What do you have there? Like a little she has a walking treadmill. So they're literally she's working and then she's working out, right? That's helped you quite a bit. So in other words, try in your work, and then I have a kneeling rocker bottom chair. So write that down, kneeling rocker bottom chair. So when I want to work on my cervical curve, I'm in my kneeling rocker bottom chair, which causes to work on the computer with that, your core has to be contracted. So yeah, we can go to the gym, but just try to make working out as part of your lifestyle. What are the treatments available for Borrelia, atypical symptoms of cervical spondylosis? Cervical spondylosis just means arthritis of the neck. Borrelia is the old term. The new term I'd say is just is cervical vagopathy or vagus nerve degeneration. Now, technically, Borrelia relates to the cervical sympathetic ganglion. So basically, the head, the face, the heart, the sympathetic ganglion in the neck also run right in front of the cervical vertebrae. So basically, those ganglion could get stimulated, so you get tachycardia or you get migraines or this or that. The treatment, again, is just you got to restore health to the cervical spine. You got to restore health to the cervical spine. Military, neck, terrible headaches. Oh, the trapezius muscle. So remember I said the carotid sheath, The spinal accessory nerve is in the carotid sheath. The spinal accessory nerve that innervates the sternocleidomastoid. So if you have dystonia, like you're going like this, you have dystonia, or you have tightness in your trapezius, you probably have irritation of your spinal accessory nerve. It's the same thing. You can document that there's irritation of that nerve by doing ultrasounds, and you'll show the compression of the jugular vein. Why I talk a lot about compression of the jugular vein, because that's the structure in the carotid sheath that's most compressible. So if that's getting compressed, pretty much everything in the carotid sheath is getting compressed. The carotid artery, because it has a muscular wall, it's very hard to compress that. But all the nerves, the glossopharyngeal nerve, which has to do with blood pressure and swallowing, spinal accessory nerve has to do with the trapezius and the sternocleidomastoid muscle, and then the vagus, which has to do with all the internal organs. So anybody who has an internal organ issue and they're like, yeah, but my trapezius is always tight, my neck cracks, I got in a car accident, or I had a lot of chiropractic care, it's likely your internal organ problem is going to be from ligamentous cervical instability. Is it safe to use Adenerol and over-the-door neck traction? So if you have ligamentous cervical instability, you're not really supposed to do neck traction because that could make it worse. If you have a lot of arthritis, right, you don't have instability, you just have arthritis, a cervical neck traction device could be helpful. And Adenerol, when you lay on it, that gives you a cervical curve. So that's one of the things that you can use to get a good cervical curve. Would you recommend continuing or stopping chiropractic treatment if you think that you are experiencing issues to cervical instability? If you research on the internet, if you have ligamentous joint instability, like that's your primary diagnosis, it's contraindicated. You're not supposed to get high velocity manipulation. Is DML so good? I used to give it IV. I gave it a lot of years IV. It's very, very good to get rid of pain. It's very, very helpful. It's water and fat soluble, and a lot of people get a lot of good relief with it. So basically, how can I pinpoint where a pinched nerve is? So normally you would get oblique views, like you would do an X-ray and then you would go like this. And if you see here, the neural foramina are open, the person extends, and then there you get where the nerve gets pinched. So you can actually tell exactly where the nerve's getting pinched. The treatment of that usually responds really good to prolotherapy. So you have dynamic nerve entrapment. So in other words, certain motions, the nerve, there's plenty of room for it, but you do a certain motion and then it goes like that. It means the connector is the ligament connectors are not strong. So prolotherapy, by strengthening the ligaments, they're the capsular ligaments, then it stays open and the radiculopathy goes away. Yeah, prolotherapy is very good at getting rid of cervical radiculopathy or lumbar radiculopathy or sciatica. Why do you think my doctors have never been able to locate my entrapped nerves? Well, they probably didn't do motion x-rays. Like they're just doing MRIs. You got to do motion x-rays because it's dynamic, because you could lay down and there's no entrapped nerve, but when you move a certain way, then all of a sudden it gets entrapped. So that's what a digital motion x-ray shows. What is the difference between, instability is the actual condition and it causes a nerve entrapment. Can you fix nerve impingements? Yes, like even vagus nerve degeneration is too much compression and stretch on the vagus nerve. So if you restore your cervical curve, when you have a normal cervical curve, typically everything is in its shortest position. Shortest position, meaning that the vagus nerve isn't stretched, the internal jugular vein isn't stretched, the spinal cord's not under tension, right? And in the office, I'll explain it this way. I'm like, Margaret, let's say you're my prolotherapist, right? I'm all hunched over, right? I'm all hunched over. And I'm like, can you do prolotherapy on my back? You're going to say, yeah, I can do prolotherapy on your back, but you got to get unhunched. So many of you, you're walking around with your cervical curves horrible. So it's just like me with my back. In other words, it's too much pressure on the ligaments. When you lose your cervical curve, everything is stretched. The nerves are stretched, the vagus is stretched, the spinal cord is stretched, all the nerves are stretched, so it can cause pretty much any symptom. I was told many years ago I have Meckel's cave, trigeminal cave, and that it meant nothing. Can you discern if there's pressure on the nerve using ultrasound? Okay. The trigeminal nerve, it's a kind of a tricky nerve. You kind of got to assume yay or nay it's affected. So in other words, you can get an MRI of the cranial nerves, but I'm telling you, trigeminal nerve issues, it misses it a lot. So I just want to explain the trigeminal cervical nucleus. So the trigeminal nerve, that innervates all the sensation of the tongue, the mouth, the face, the TMJ, the eyeballs. Um, then the trigeminal nerve goes to the arteries in the brain. So if you look up, like, what's the pathophysiology of migraine, you'll continually see the trigeminal nerve is irritated. The trigeminal nerve is irritated. Or you have burning mouth syndrome, or your eyeballs hurt, or you have dry eye disease, or you have some weird facial pain, right? It's likely you are having irritation of your trigeminal nerve. The trigeminal nerve, the neurons, the nerve cells that make up the trigeminal nerve go all the way down to C2. So that means that you could have atlas instability, you could have any kind of pathology at the cranial cervical junction, and that could irritate the trigeminal nerve. So what we do with cases where we believe there's a trigeminal nerve issue, we would do digital motion x-ray, we would do upright cone beam CT scanning to see if there's upper cervical pathology, and if there is, normally when we treat the upper cervical pathology, the symptom goes away. Give you an example. So I had a new burning mouth patient about 2 weeks ago. So I said to her, because who knows how often the upper cervical nerves have been irritated in you, because she might have had, I think she had it like 7 years she had burning mouth. Like, can you imagine, like 7 years your mouth feels terrible? I mean, it's just a horrible condition. So I said, I think on the first visit, we should use platelet-rich plasma. Why don't we just do this? And it's not 100% guarantee, but this is one of the discoveries that I made. So I said, why don't we do this? What I'll do is, under ultrasound, I'll block your C1 nerve, your C2 nerve, your C1 nerve, C2 nerve. And then, we'll block it. So that way, when I put the PRP in there, won't hurt as much. And then we'll see, does any of your symptoms go away? And realize this lady had had this condition for years. So when I finally went in there to do the PRP, it's like, how are you, Margaret, how are you doing? And she's like, Doc, 90% of my burning mouth's gone. So it's not 100% guarantee, but that's one way you can see, does a trigeminal, does a symptom that you think is trigeminal, does it have its root cause in the cervical, is by blocking those nerves? Okay. I have severe low back pain. Can your test determine if it is from IBS, basically problem, muscle issues, or spinal disc disease? That's a good question. Because remember I said irritable bowel syndrome can also be the vagus nerve. So what we would normally do, again, we would make sure the person's done the normal stuff. Like, have you tried diet? Have you tried eliminating gluten, dairy? Is the person like an overly stressed out person? Do they laugh? Do they have good personal relationships? Then what we would do is dynamic digital radiography of the lower back, because you could see, like in this particular case, there's instability here. There's instability at L3, L4, and then we would do the same thing in the neck, and then, treat the instabilities. DMX is not available in my region. Is there an alternative? Yeah, you can. You can simulate it. You can simulate it by, you can simulate it by doing still x-rays, but what happens with digital motion x-ray, as you do passes, you get more and more motion. So it's really important if you get flexion extension x-rays or you do open mouth x-rays that the muscles are relaxed. So in other words, if your muscles are tight and you do stills in certain positions, or you do an x-ray where you flex, if the muscles are tight, it may not show the instability. So you got to try to relax the muscles before you get the x-ray. Some people have muscle relaxants, take some muscle relaxants before, or put heat on it, but try to relax the muscles. Say you get an initial assessment at Caring Medical, then want to receive treatment 6 months later. Will they still be up to date? Yeah, I mean, it's kind of like, did the symptoms change or not? So obviously, if the symptoms didn't change, yeah, those tests are going to be fine. But if the symptoms changed, you often got to reduce some of the tests. So it's really, did the symptoms change or they didn't change? Symptom-related questions. What causes crepitus after a whiplash injury? That's ligament damage. Can it be reduced, cured with prolotherapy? Yeah, normally prolotherapy is very effective for that. It seems that my tachycardia is related to poor digestion. I just want to talk about the gastrocardiac reflex. So basically, if you have vagus nerve degeneration, basically what happens is your stomach often doesn't work right. So you eat some food, it sits in there, and then the vagus is supposed to be stimulated to get the food out of there. It's supposed to get it digested. Well, what can happen is, as it just sits in there, basically then the vagus starts innervating the heart and you get bradycardia or you get tachycardia. So if you're somebody who has food or bloating or burping or something relates to your heart, you probably have gastrocardiac syndrome from vagus nerve degeneration. Is there anything to help if I have active uncontrolled rheumatoid arthritis? So this is a PANIS. So basically, rheumatoid arthritis, the natural treatment of rheumatoid arthritis, what I normally would recommend to people is you should probably fast for a week or so. Like fast for a week and see if your rheumatoid numbers go down, because then you know that a certain percentage of it's related to food. Then you got to figure out what foods are causing the rheumatoid arthritis to be activated. Then anyone with an autoimmune disease should make sure that they're very, very positive. So tell me, like, we're on number 57. So what are you guys suggesting? Should I go, just keep going?
Yeah, keep going.
Okay.
Saying take a drink of water.
Okay, no, we're doing okay.
Okay.
So long story short, you got to make sure when you have an autoimmune disease, you don't have self-condemning viewpoints of yourself, right? I could tell you story after story about somebody having, like, their business is going under or they're getting a divorce and they're just like, I'm no good, I'm no good, I'm no good, or they have negative thoughts about I'm losing money, I'm losing money. Like, you can't have negative thoughts continuously and think something good's going to happen to your body, something's bad. So you got to change it. That's why I look at myself as a beloved son of God. Like, God loves me. My sins are forgiven through Jesus Christ. God has a plan for me. I'm going to live forever with him. I try to look at the positives in my life. I try to limit how much negative stuff gets into my ears. And so that way, when negative things happen, I'm strong and can handle it, versus like I'm continuously thinking of negative things. So basically, if somebody's rheumatoid arthritis is under relatively good control, then you can do prolotherapy, but you don't do prolotherapy when somebody has active rheumatoid arthritis. Has Caring Medical had success treating someone with severe back muscle spasm? Yeah, that's a common thing we see with prolotherapy. This again shows that when I burp, I momentarily pass out. That's the gastrocolic reflex, bloating. Yeah, then you get bradycardia. So the treatment is you have got to chew your food till it's completely digested in your mouth. So in other words, if this is you, you have to chew your food till it's a liquid, uh, and then if you have vagus nerve degeneration from your neck, you've got to straighten out your neck. I have been getting high blood pressure readings after a stay in the hospital. Everything's come back negative. The sensors for blood pressure are the glossopharyngeal nerve and the vagus nerve. So if you have compression of the carotid sheath from bad neck curve or neck instability, that can screw up the blood pressure sensors. So you should look at, do you have vagus nerve degeneration? Do you have ligamentous cervical instability? So I get lightheaded when laying on a dental roll. So if you have atlas instability, when you lay down, the vertebral artery can get compressed. So instead of extending your head all the way when you're on the dental roll, put a pillow here and have your chin go more forward. And that should give the vertebral artery enough room, and then you won't get dizzy. Hiatal hernia, digestive problems, low weight, hormonal imbalance. I've been dealing this for years. It got worse after a hysterectomy. I still have my ovaries, but currently going through menopause. What can I do? So, long story short, so obviously I would go to a functional medicine doctor to get all the hormones checked, right? Get all the hormones checked. And then obviously, if somebody has digestive issues and anxiety, we're all thinking vagus nerve. So you really should get the neck checked out to see if you have cervical vagopathy. And then I just wanted to explain the diaphragm attaches to like the ribs, the thoracic vertebrae. So you could have lung problems, breathing problems, heart problems from instability in the chest or the thoracic. So if somebody said, I get palpitations, and when I move, I feel cracking, clicking, then you should, if you want to just test if it's related to instability, you wear a thoracic brace, right? If you wonder, do I have symptoms of cervical instability, you could wear a cervical brace and just see if your symptoms are better. And then, so then the person would need prolotherapy in those areas. Skull base, CSF leak, compressed jugular, they were repaired surgically. I'm left with a constant pounding head. Like basically they have pulsatile tinnitus. See how the carotid artery is hitting the jugular? So this is what a CT venogram looks like with pulsatile tinnitus. So that's what you're looking for. It's a CT venogram. I get a lot of questions about SIBO. SIBO is there's extra bacteria in the ileum or the small intestine. I think this is almost always caused by low stomach acid, which again is a vagus problem, and incompetence of the ileocecal valve. The ileocecal valve keeps the small intestine away from this large intestine. When the vagus nerve doesn't work right, the ileocecal valve can be incompetent, and then the bacteria from the colon go into the small intestine. So when we do prolotherapy, we correct the curve. Often the SIBO problems all go away. The many mechanisms by which cervical vagopathy can cause small intestinal bacterial overgrowth. All these things, because of injury to the vagus nerve from neck problems, can lead to all these things, which again makes somebody more prone to small intestinal bacterial overgrowth. So yeah, if you look at this paper, you'll see that people with small intestinal bacterial overgrowth have ileocecal valve dysfunction. The stomach pH is higher, the small intestinal pH is higher. All this is looking like cervical vagopathy. And then this is just explains all the things that if you have ileocecal valve dysfunction, you get all kinds of problems, digestive problems. So the treatment is to restore the electricity, right? The vagus nerve electricity to the intestine. Is there anything I can do to relieve symptoms to improve my neck alignment? Yeah, like what you need to do is like that's our nephew Levi. It'd be better instead of having your kid do that, have your kid do this. This is Izzy's child, Will, her oldest. Even Will knows how to use prism glass. And of course, all of us need to elevate our computer so we have good posture with the computer. So neuralgia. Neuralgia means that there's stretch compression on the nerve. Eventually, if there's enough stretch or compression, the nerve will get inflamed. And if there's too much stretch or compression, you're going to get neuropathy. And neuropathy means that the nerve is starting to get damaged. You can restore the cross-sectional area of the vagus. The vagus can repair, as all nerves typically can repair, if the cause of the nerve injury is resolved, which normally relates to posture. Does prolotherapy help with forward head posture? It does, in the sense that you get stable, then the muscles work better, right? We all know that if you injure the ligaments on your knee, you're not going to have a lot of power in that knee, right? So imagine if you got ligamentous instability. Often people will say, well, my head feels too heavy, right? So you can understand, if you restore stability to your head, you're like, oh my God, I have so much more muscular power. And of course, that helps with forward head. I had a cervical discectomy, installed a cage. I wake up every morning with a migraine. Any ideas? I just wanted to put this in here. See, when you get disc replacements or you get artificial body parts, those artificial body parts are way, way more stronger than your ligaments. For instance, if somebody had a knee replacement and now they still have pain, with every step, the force is going onto the ligaments because the knee replacement is many times stronger. So often we find ligamentous joint instability in people who've had these various things. This person likely has ligamentous cervical instability. Like, you might say, well, how can you say that, doc? Well, if they have fusion of C2 to C4, where do you think all the motion's coming from? They're going to end up having instability below the fusion and above the fusion. The lateral part of my back has pain. It radiates to my right chest, and it aggravates my blood pressure. Okay, so long story short, there's a muscle called the omohyoid muscle that goes from your shoulder here to your hyoid bone, that some people, when they turn, that can compress the carotid sheath and elevate the blood pressure. So again, this is sounding like in this region, there's some compression of the jugular vein, and the treatment would be to document it with ultrasound. And again, if there's cervical destructure or breakdown of the cervical curve, to do cervical curve correction. Burning mouth, I look at it as sciatica of the trigeminal nerve. So it's sciatica of the trigeminal nerve. So basically you have irritation of the trigeminal nerve. It's from irritation of the nerve roots in the neck that irritates the trigeminal nerve. Once you correct the problem, the ligamentous instability in the upper neck, then the burning mouth eventually goes away. My right cheek swells, lips and tip of my tongue sting, my nose is hypersensitive to smells. Are these common symptoms with burning mouth syndrome? Remember I said burning mouth, trigeminal nerve. The trigeminal nerve does the inside of the nose, the eyeball. All these things can be from the trigeminal nerve. And ligamentous cervical instability irritates the trigeminal nerve, and you can get all these weird symptoms. 3 years of intermittent pain caused by lifting a box. Pain present in the back of the throat. The vagus nerve, glossopharyngeal nerve, innervates the back of the throat. They have sensitivity to the sternum, nausea. And then basically the way you document gastroparesis is you do a barium swallow. The barium swallow test, all the barium should be out of your stomach by 90 minutes. So if there's still barium in there, it means that the electrical supply of your stomach is not normal, and that's from the vagus. I recently found out that the surgeon didn't reattach the styloid muscle. So basically, these are all the different things that can cause blockage of the jugular vein. One of the things that causes block is an elongated styloid. The way you find out if you have an elongated styloid bone is usually by CT scan. So you have to get a CT scan. And then the styloid, if you rotate your head to the right, the styloid can block the jugular, and if you flex. So if you're somebody who has to sit up in bed, you have to sit up in bed just to go to sleep instead of flat, you may have a elongated styloid, so you should get that checked out. Can your neck be unstable if you can't move it at all? Yeah, absolutely. Because again, if you have ligamentous cervical instability, the muscles clamp down through the ligament muscular reflex as a protective mechanism. And then when you have a subluxating jaw, that again is ligamentous instability of the temporomandibular joint. Certain head movements, especially looking up or down, can cause a sudden change of my eyesight and distorted vision, including change of the angles and spaces. Yeah, ligamentous cervical instability causes block of the jugular vein. Blocking the jugular vein also ultimately is going to cause an inhibition of the fluid flow out of the eye, because the eyes drain in the episcleral veins, which drain into the cavernous sinus, which drains into the internal jugular veins. So definitely, if you have blurry vision, and we have a couple of really good papers coming out on where we looked at like 203 people with like different eye symptoms, and there was a like around 90% of them had vagus nerve issues, about 98% had jugular vein compression at the atlas. So if you really are having blurry vision, you got to look at, I probably have block of my jugular vein at the atlas. How can you help someone who is severely anemic? So anemia, if you don't know the cause of it, it's probably low stomach acid, which again can be cervical vagopathy. So the vagus nerve causes hydrochloric acid to be released, and hydrochloric acid helps somebody absorb and digest iron. Okay. Cervical instability. I just wanted to put this on here. So basically, under ultrasound, you can see the vagus nerve. You can see the vagus nerve. Here you can't see the vagus nerve. So you could see in this particular patient at the atlas, you can't even see the vagus. So the vagus is just getting annihilated at the atlas. This is a test you could get pretty much anybody who's competent with ultrasound. It's one of the common tests we do at Caring Medical. He had a neck fusion C1, C2, and at times there's blurry vision, dizziness, and loss of balance. So basically, when you have a fusion of C1, C2, you got to realize you could have instability then at C0, C1, or C2, C3. So when somebody has these symptoms after a fusion, it's normally that they have instability above the fusion or below the fusion. Is PRP or normal prolotherapy better for craniocervical instability? It depends on the individual. So some individuals do better with PRP, some individuals do better with regular prolotherapy. Can issues with cervical spine cause lightheadedness and head pressure when turning or bending the neck? Yeah, absolutely. So you could just sort of look at this like there's so many different ways that ligamentous cervical instability causes dizziness. So if you've had dizziness and nobody can figure out the cause, it's likely going to be ligamentous cervical instability. My son is 21 years old and has daily aches. He can't drive or be by himself. Usually sits in dark rooms, daily headaches, killing him slowly. Yeah, so like this is like would be a classic case that they have ligamentous cervical instability, because the person can't be upright, because if they're upright, they just feel terrible because basically the head's sitting on a broken neck. So ligamentous cervical instability means that you have a broken neck. That's why it's so serious and it's a progressive disorder. It has to be treated. It has to be treated. So the normal broken neck is you break the bones, right? That's the one that we're all familiar with. But a broken bone in the neck or a broken ligament in the neck is so significant because it can lead to instability. Instability means the bones are moving in ways that God never intended. So if it moves in a way and it blocks the CSF, your brain pressure goes high, the kinks on an artery, a certain part of your brain doesn't have the circulation, of course, it can hit nerves. So basically, if you have a ligamentous cervical instability problem injuring the vagus nerve, you get leaky gut. Leaky gut means that the gut-associated lymphoid tissue get exposed to a lot of stuff, and basically the mast cells in the body, in the lumina of the digestive tract, they go crazy, release a bunch of histamine. So when I see mast cell activation syndrome, in the clients that I see, because a lot of them are loose jointed, it's normally associated with ligamentous cervical instability. And then this just kind of shows that this kind of a complicated slide, but basically the vagus nerve innervates the enteric nervous system. And then each vagus nerve cell innervates about 3 to 5,000 enteric nervous system cells. So you wipe out one vagus nerve cell, you're wiping out 3 to 5,000 nerve cells for the digestive tract. So then, of course, the person's going to get leaky gut there. So basically, the body's going to mount an inflammatory reaction, histamine reaction, and then you get mast cell. Can lifting slightly heavy objects and sitting trigger migraines? Yeah, that's exactly right, because it's going to trigger it. I have been diagnosed with idiopathic intracranial hypertension, MS, and migraine. Doctors cannot figure out. Yeah, definitely that trio normally signals to me that you have ligamentous cervical instability. So get the right test for ligamentous cervical instability. Styloidectomy, they shave the C1 transverse process. They remove the digastric muscle because of jugular vein compression. Could this cause instability? Yeah, of course it could, because now you don't have the transverse process of the C1. So, and I would even say you might have already had ligamentous cervical instability. So maybe that, because if you haven't been checked for ligamentous cervical instability and you get all these operations, you might have had the ligamentous cervical instability was actually the cause of the various problems. So yeah, get tested for ligamentous cervical instability. How is instability in the rib cage diagnosed? Honestly, we've done different things. There are ultrasound tests and this and that, and of course we do dynamic digital radiography. But honestly, like one time I turned over in bed and all of a sudden crack. I felt the crack. Then all of a sudden I would move and crack, 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 crack. So like a lot of times, the rib cage is so superficial. So if somebody's moving and you feel crack, 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 you don't need to spend a bunch of money to do a fancy schmancy test. You got ligamentous rib instability or slipping rib syndrome, and prolotherapy is very, very effective for that. Yeah, this just shows. So the attachments of the ribs are in the back here. So we look at the attachments in the back, and then we look at the attachments in the front, and whichever ones are loose, those are the ones that we treat. Instability is a progressive disorder like we talked about before. I am 74 with prior tinnitus due to hearing loss, recurrent tinnitus after over manipulation. So yeah, you just got to be careful when somebody's twisting your neck, like one twist too much and you could be left with ligamentous cervical instability. So to me, it doesn't matter if somebody hears a noise and they get increased tinnitus, or they have pulsatile tinnitus, or all the different kinds of tinnitus. They normally all stem from ligamentous cervical instability. So I don't get into too much about this tinnitus is because of the vestibular nerve having fluid, or the carotid arteries hitting the internal jugular vein, or the internal jugular vein is getting hit here or that. They all stem from a breakdown of the cervical curve and or ligamentous cervical instability. Okay, there's different kinds of genetic things that cause congenital fusion. So if somebody had fusion of C2 to C4, even in a youngster or a 6-year-old, they're probably going to have instability above it. So then the instability above it. So in kids, I'm seeing more and more kids that we just help them get a good cervical curve. If that resolves the issue, that's great. If it doesn't, then yeah, you got to get prolotherapy. So, prolotherapy is really, really effective in kids. Vagus nerve, somebody could have a childhood injury and they could have vagus nerve issues their whole life. This just shows that the vagus nerve usually gets injured at the atlas. There's a difference between vagus nerve degeneration, which is where you do an ultrasound and the vagus nerve is very small. That's called vagus nerve degeneration. Or somebody all of a sudden they turn their head or they sleep in a certain way and their pulse rate goes way up. That's from a vagus nerve conduction block. So conduction block means that some of the nerve impulses in the vagus are getting blocked. So that could cause what? The stomach doesn't make stomach acid. The heart goes into an arrhythmia, swallowing gets affected, or all of a sudden you lose your voice, or the vocal cords can't open, so then the person feels like they're choking and they can't breathe. And then the vagus nerve is involved in regeneration of the body. So if you're a person who all of a sudden everything, like you went from a little bit of a problem to pain all over your body, you probably have a vagus nerve issue. Or all of a sudden you have inflammation in your body that you can't get better with diet and other things or herbs. You probably have a vagus nerve issue because the vagus nerve is what relieves inflammation all over the body. Monica just wanted to let us know that she got a styloidectomy. So we had done a bunch of testing. She did a styloidectomy and she did really really good. So if somebody has jugular vein compression or vagus nerve degeneration from a styloid problem, and they still have some residual symptoms from ligamentous cervical instability, we can start prolotherapy like 6 weeks or 2 months after the styloidectomy. Uh, yeah. Then, I think Chad or somebody Chad had told me he was on the last webinar, but Chad had said he touches a C5 or something and he gets like zaps down his back or this or that. If you're somebody who can just touch something and you get like some horrible symptom, that usually means that you have dynamic spinal stenosis. So it means that just that little bit of tap is moving the vertebrae 1 millimeter or something, and then that irritates the spinal cord, and that's why you got this symptom. And then this just shows that there's people that when they come, they have something like this. You could see that there's not a lot of space there. So somebody who has this, there are times where you have to have a decompressive surgery. But it's amazing. Like, look at this curve. It's completely reversed. There's not a normal curve. So if this person got a normal curve and if there's instability right here, it's amazing how many symptoms get better. Okay, case review. So Dhruv, are we gonna talk to him?
We just had one quick question.
Okay, yeah.
Patient of ours had the question about a styloidectomy and her styloid muscle was not reattached
Yeah.
after the
Yeah, the
styloidectomy.
muscles that attach to the styloid, normally, when you get a styloidectomy, those attachments aren't there, but they normally don't cause a problem. Like, we haven't had them cause a problem. Hey, Dhruv, how you, bud? Can you hear me? I can't hear him.
It needs to be made a presenter.
I think Michaela has to say that. Hold on 1 second.
Can you hear me?
I can hear you. Can you hear
Okay.
me now?
Sorry about this, everybody. Can you hear me, Dhruv?
I can hear you,
No.
Dr. Ross. So, am I audible?
Turn up volume. Hey, hey.
Doc, you hear me now? I just disconnected my earphones.
I can hear you now. Can you hear me? Can you hear me?
Hello.
Hello, can you hear me?
Dr. Ross, I can hear you. Can you hear me now?
Yeah, you felt pretty bad, huh? Since you were a youngster, huh?
Yeah, that's correct.
Where are you calling from? Where do you live?
I'm from New Delhi, India, and it's actually 4 a.m. right now.
Okay, thank you for being up. Thank you for being up.
Thank you.
Can I ask you this? Did you have a job where you were working on the computer a lot?
Uh, I would say that I've had these symptoms pretty much all my life, even before I began working on a computer. So I don't think that poor posture caused this, to be honest.
Okay. And then the, so you felt bad your whole life, basically. What's your
Correct.
symptom? What's your worst one that you wish you didn't have it? What's your worst one?
Honestly, I feel bloating and indigestion, and I think that is something that is causing a ripple effect and causing all those problems. Like I have oily skin, I have gray hair, I have acne,
Okay.
even yeah.
And you've changed your diet?
I've just started eating cleaner, and that's pretty much it. Just cut out a lot of junk food that I used to have. But honestly, I don't feel massively different. But I've been doing curve correction exercises. I also did attach my X-ray in the case that I sent over to you guys.
Okay.
Uh, it's in the email. I think Michaela can pull it out for you, if
Yeah,
that's
I think
possible.
it's right here. So you definitely have a cervical curve. So have you been working at it? Try to get your cervical curve?
Uh, I'm sorry. Are you saying that I have a C curve or
Yeah, no,
do I
you
have a
have
straight?
some lordosis. So have you been working on your curve or not really?
About like since the past 15-20 days, that's pretty much it. Yeah.
Okay. Did you get any x-rays to look for instability or no?
Yes. Like we don't have a digital motion X-ray where I live, but I did get the anterior X-ray that I had attached in the email.
Okay. Do you
Yeah.
have clicking, popping, grinding in your neck or no?
Uh, no, absolutely not.
Okay. Do you have stiffness in your neck?
No, absolutely not.
Okay. Okay. No, so I mean, so part of it is normally when you have ligamentous cervical instability, you have clicking, you'll have popping, you'll have
Hmm.
neck pain, right? So you may represent somebody who it actually isn't a ligamentous joint instability problem. When I was talking about gastrocardiac syndrome, do you think that might have applied to you? When I was talking in the webinar
Hmm.
about, where you eat and then it affects your heart, does that ever happen to you?
No, absolutely not. That hasn't happened to me ever.
Okay, okay.
It, yeah.
And then, but you're saying your uvula does deviate to one side, right?
Yes, that's correct.
Which side?
Uh, it's always I'm not sure, but it's never been straight. It's been deviated all my life. I think like I can check it out right now if you want me to, but
Okay,
I'm assuming it's my left side, to be honest.
okay, okay. So you could have what's called thoracic outlet syndrome. Like in other words, sometimes it's not a neck issue, it's
Mm,
where the jugular vein and stuff goes right here. It
mm.
goes right here. So do you have a doctor there in India? Do you have a doctor?
Honestly, I've just been Googling stuff on YouTube, and
Okay.
so
Okay,
not
so I
really.
want you to look up thoracic outlet syndrome. So I'm going to give you like some crazy advice. You ready for some crazy advice?
Yeah, sure.
Okay, so I want you to hang on a bar. Like, like
Mm,
you hang,
mm,
you hang on a bar. So
mm,
I want you to do that. I mean, obviously, uh, you might just do 5 seconds, where you're hanging, because it'll
mm.
open up your thoracic outlet. It's one of the easy ways to open up your thoracic outlet.
Okay,
Okay, and then what I'm going to do is, like, for a couple weeks, I want you to try to keep your elbows at your side. Like, a
okay,
couple times a day, go like this, you don't get a frozen shoulder. Like, in other words, let's get rid of like the movement of this. Like, if you work on the computer, just work like this. So, in other words, let's open up your thoracic outlet. And then in 2 or 3 weeks, you just let me know, like, you feel better, you don't feel better.
yeah,
And I
sure,
can
I'll do
send
that.
you some more stuff on hanging, but
Mm,
research a little bit about hanging and the benefits of hanging. You know what I mean? Like, you take a tree branch or you take
got it, got it.
okay? Eh, So long story short, so normally when you have bloating and this sort of thing, if you want to figure out if food is an issue, you would fast for like a week. Have you ever done
Mm.
that?
No, never.
But you know what I mean? Like, you might want to just fast for a week,
Eliminate.
drink
Yeah,
water, and just see like how many things get better. If you're 75% better when you don't have food, you got to figure out what food's causing some of this stuff. And again, the jugular vein in the vagus probably still is involved, but the compression isn't in the upper neck. Like I talked about there, it's probably the thoracic outlet.
Understood. Yeah.
Okay, so I'll go to the next one, but thank you for presenting your case.
Thank
Thank
you
you for being
for, yeah,
up too. Okay,
thank you.
thank you. So Vicky, you guys will get Vicky.
So Vicky is actually left the chat, so we're
Okay,
trying to get her back on.
Okay, so Vicky left, but let's just talk about 65-year-old. Oh, she had right vocal cord paresis. So we're thinking the right vagus nerve got injured at some point. She saw some probably prominent doctors there. She tried a bunch of things. My breathing is affected. I sound hoarse. No. So she would be she has dysphonia, so she has problems speaking or painful speaking. You could see where it looks like she has a lot of things that are related to the vagus. So she would be, I think, an ideal candidate to look at for cervical vagopathy.
Okay, she was.
Okay,
Trying to get her
if she
back,
comes back, we'll get her. But you can see hoarseness, difficulty breathing. These all look like that there's a vagus nerve issue on the right side. So we would look for what? Jugular vein compression on the right side. It's likely Vicky has to sleep on her right side, right? Because the problem's on the right side, so she has to sleep. So we would find that probably her jugular veins are more open on the right side. And this just kind of shows it. This is the recurrent laryngeal nerve that innervates the vocal cord on the right side. So they're basically saying the muscles in your vocal cords that have to do with speech and your larynx and through which air goes, right? So you can understand the vagus nerve, the recurrent laryngeal nerve innervates the muscle that opens the vocal cords. So if your vagus nerve is injured on the one side, the vocal cords have a problem opening, so you have airway resistance, so you could feel very short of breath. So the treatment would be restore the neck curve and restore the instability. This is Jeff. I put this on here just to show SIBO can cause 800 million things. This is just all the things that small intestine overgrowth. Is Jeff going to be on or no? Okay. So Jeff just said he's had several bouts of SIBO. He had a neck fusion C3 to C7. I'm just telling you, if you've had a fusion of L4 to L5 in your lower back, it's probably you're going to end up having instability at L5S1 if you still have symptoms. So Jeff should get tested for C0, C1, C1, C2, C2, C3 instability. So he needs a digital motion X-ray or something like it. And it's likely he's going to have instability. And then he's saying that he also is having pain down his arm, his Adam apple. So all this stuff relates to ligamentous cervical instability that he got. So basically, he needs like various ultrasounds to see if his vagus nerve is getting injured, and where it's getting injured in the neck. So these are to show some ways to do ultrasound testing and looking for is there vagus nerve stretch and compression. So Jean okay. So Jean's 59. She had endoscopy in December. They didn't find anything. She had another one. She had an esophageal manometry test. So it's basically, she probably has dysphagia, like she feels like there's a constriction. Oh, she was diagnosed with achalasia. So remember we said gastroparesis is the nerve supply to the stomach. Are you Jean?
Yeah. Hi.
Hey, thanks for being on. Where are you at?
In Southern California.
Okay, thank you. So
Thank
it's like
you.
4 o'clock there, right?
Yes, it is 3:40. It's so good to see you. You're my hero.
Oh no, I'm just a person, but no, I still enjoy what I do. I've been doing prolotherapy for 33 years. It's hard for people to understand, like all this stuff, I've just been doing it for 33 years. It's sad that people will be like, what the heck? Like, I never heard of this, right? Like, I never heard of this. Why don't you explain for the people that are listening, what symptoms does achalasia cause? Like what, and how disabling is it?
It's incredibly disabling. It's difficult to swallow. It feels like everything kind of sits down in here. Lately, the last few weeks, it's felt like like it's sitting up here even, which wasn't the way before. So I can't eat much. I throw up everything that's mostly with mucus. And I've been starving since September. Yeah, I've lost weight. My body feels like my clock is off. Like it's wreaked havoc with my body.
Okay.
Like it's like I'm up and I'm just up and because of the weight loss. I don't know why, but I mean, it's the lack of food maybe, but yeah, you can only eat small bites.
Do you have clicking, popping, grinding in your neck?
No,
Okay, so no neck pain.
no.
Okay. No, so I want to say this too. I definitely have had cases where they still had ligamentous cervical instability, even though they didn't have the normal symptoms. Because it's hard to understand how you could have ligamentous cervical instability without a lot of neck symptoms, but it does happen. Have you had motion tests or any kind of flexion extension or open mouth x-rays?
Yeah, I had submitted one to you guys in the email and I have the others. I have an open mouth, I have flexion extension. The report it says that they're saying no evidence of instability on flexion or extension on the still pictures.
Okay, and did you have the open mouth where you tilted? And that was good too.
The open mouth is a single still shot and it just shows my C2 rotated to the right slightly.
Here, do this. Okay, so this is important, okay? So I want you to get where you open your mouth, but I'm telling you, this is the key thing. When you do the test, you have to jut your chin forward, then do that.
Wow.
And then do a still on the right and the left. And honestly, I would do 2 stills on the right and 2 stills on the left, because just in case they miss it. Because you'd hate to like go through a whole bunch of stuff when you have ligamentous cervical instability, because that, of course, there's treatments for it. Now,
the picture says I have a military neck, if that's what you all call it.
yeah.
I don't have a curve.
Okay, so let's just talk about some things structurally you could do. Because obviously in our office, we would try to figure out, is the vagus nerve getting stretching compression here, 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 here? Like, like the last patient, Drew, it probably is something down here instead of up here, because 95% of the people it's up here, I tend to talk about the stuff up here. So basically you have to restore your vagus nerve function, right? Like, that's probably the thing that's going to help you get better. So obviously work on your neck curve. So you're going to do that. Then can I ask you something? Do you feel like you have other vagus nerve symptoms? Like,
no.
Okay. So you don't have, okay. No, that's interesting, right?
Nothing. No. And I have been,
head pressure. You don't have head pressure. Your vision is fine. Okay.
So they did an endoflip, a manometry test. I was diagnosed in January. This POEM surgery that I saw them in February. It's scheduled for April 9th. And that's next week, because I wanted to give myself I wanted to try and fix this and have it on the books. Yeah. And I'm going to tell you what, I took a downfall, which I emailed Michaela.
Yeah.
And I couldn't even drink soup, Dr. Hauser, on Saturday. I couldn't, like, liquids. And I got panicked that I would have to go to the ER, because if liquids are the only thing you got and you don't have that, then you're in trouble. So I connected the dots. I sat there on Sunday and go, why did I lost 5 pounds in the last 5-6 days.
I'm so sorry.
Why? You know why? I connected the dots because I do these little exercises twice a day for my neck. You know what? I stopped doing them because I didn't think that they were working.
Okay.
And I crashed.
Okay. I'm just things that sometimes are helpful. So I'm just going to give you a few things that sometimes are helpful. Obviously, I still think you need the motion test just to double check, that there's nothing.
My chiropractor said he wouldn't be able to get insurance to pay for that one. I asked him when he ordered the tests and the x-rays, and he's like, I can't get your insurance to pay for that.
Okay. Well, I mean, sometimes you just got to go to a place and, cash talks and they'll give you a big discount or,
Right.
but long story short, so when someone's losing a lot of weight, like they come to see me and it's like, they're on the verge of getting a feeding tube or something, we'll just go through things that you can do that might help right away. So I'm just going to go
Okay.
through the normal thing. So normally what we would do is we would figure out what position the jugular vein is most open. Let's just try to figure it out in you. Is your uvula midline or does it go to one side?
I've tried since I've been watching you in January. I look all the time. It doesn't do anything.
And
It's
it
just right in
goes,
the middle.
I know, does the palate rise when you go or it just stays there?
I think, yeah, it rises, but it's equal. It's
Okay,
even.
okay, so that part's good. Then do you have any tension down here or here? Okay. Do you feel, so have you tried laying, well, so basically it's this. When you're gonna go eat, what you do is you lay on your right side because the vagus with digestion normally is the right. So lay on your right side with your chin up and you breathe slowly through your nose for like 5 to 10 minutes, just to try to have the vagus not be under stretching compression for 5 or 10 minutes. Then you have to chew your food till it's a liquid, till it's a liquid. So like that's normally what we would have people do. And then we normally have them do vagus nerve stimulation. So have you tried vagus nerve stimulation?
Oh yeah, I've ever since I watched you, I'm a side sleeper. I look up. I've been taking a towel like this behind my neck, hanging my head over the edge of my bed and
Okay.
letting the weight of my head pull it
Yeah.
down. I have a little electronic stimulator that my Atlas chiropractor, I clip it to my ears. I'm doing that. I'm gargling. I'm trying to hum. I'm like, I'm doing I'm walking around with my head up like in my shoulders back because they said you got to put your shoulders back. So, I mean, I'm doing all of these things and I just feel like they're not working and they're not working fast enough because I'm starving.
Or sometimes what you have to do is get one of those pillows that's cut out.
I have a cervical pillow. I work all day. I come, oh,
Okay,
you said the
but
demo.
yeah, like the Deneroll pillow, just like, because I haven't tested you, so I don't know which way that your vagus nerves are not under tension. But I'll just say this, that correcting the cervical curve, it takes some time. So there's short-term things, but just still head the way of getting your neck curve good and get those X-rays and just let me take a look at them. Have me take a look at them. Then obviously, if the chiropractor knows somebody with an ultrasound machine, try to get your cross-sectional area of your vaguses just to see what's the cross-sectional area of your vagus.
Yeah, my chiropractors told me that it's going to take 2 years to get the C shape back in my neck.
No, no, it doesn't take that long. It
Because
doesn't.
bones,
Do you work on the computer?
I'm an accountant. Yeah, I mean,
Why
I
don't you
work
do
on,
this? Why don't you do this? Send us a picture, send Michaela a picture of you in front of your thing, so in front of your computer so I could look at it. Gene,
right.
I'm sorry that you're going through that. So here, can I pray for you? I mean, there's not much else I can do except for those things.
My question to you
Yeah.
is the do I have to get my C shape back first before prolotherapy, or should I'm doing the magnet, I'm doing the laser, I'm doing I mean, should I do that first, then do prolo? Should I jump to just prolotherapy? Or I mean, how do I
Well,
find someone here that can help me?
yeah, just do the things that, like I said, like try to see if you have instability or not, and then we'll have another conversation, okay?
Okay, so you want me to get the ultrasound of the vagus?
Yeah, and then try to get the open mouth view, the lateral flexion and just see if you have, yeah, but you have to stick out your chin.
Okay.
I think you're going to be surprised. I think you're going to end up having cervical instability, and then that would be the reason why your vaguses are having trouble. That's why like you understand, if you have a structural stretching compression of the vagus, all the vagus nerve stimulation, all that stuff, it's only going to work so much. It's probably not going to resolve it. And then, but thank you. I'm going to go to the next.
Thank you.
Thank you. Okay.
Okay, we have Vicky that came back, so.
Oh, can I?
we're gonna go
Okay, we're
back.
going to go back to
Yeah,
Vicky.
Michaela will get that
Okay.
going.
Thank you. Okay, we're gonna go back to Vicky. So Vicky, yeah, It's 8 to 7. We're gonna make it. My media team was saying there's no way you can get through all this stuff in 2 hours. It's impossible. We're gonna do it. Vicky. Nope. Okay.
No, she's coming. Hold on.
She is.
She should be
Okay.
here. Kayla's just getting here.
Right? We have a famous American, right? Robert Kennedy Jr., right? Who has that interesting voice, right? So he probably has some, he probably has some vagus nerve issues. Vicky, hey, thank you for being on. Oh, I can't hear you.
But there we go.
Okay, can you hear me?
I can, Doc. Thank you.
Okay.
I
It's been
can.
like
Thank
a
you.
nightmare for you, hasn't it? A nightmare, hasn't it?
It has been a nightmare, and it's robbed me of my life, frankly. I mean, I have breath in between speaking because of the constriction from the dysphonia. And basically, I had a Botox injection which failed to improve regarding treatment. The irony, Doc, is when I sing or when I try to sing, I have great range. I have healthy vocal cords and I've great lung capacity. I cannot sustain if I go to sing,
Okay.
I have to keep breathing. So my next step, the only step that I've been told is an EMG, a laryn, yes, laryn, electromyography, excuse me, to help determine nerve damage.
Yeah. Well, I always feel like more information is better than less information. And then you have any clicking, popping, grinding in your neck? Do you have any neck tension or not really?
No, sir, I do not.
Have
I
you
do not.
had neck evaluations? Like have you looked for instability or not?
No, I haven't, but I can always crack my neck. I'm pretty active and I do a lot of lifting and a lot of external work in regards
Okay.
to
But you
gardening
do
and
have
stuff.
cracking in your neck though.
Yeah, a little.
Okay. Okay. Well, like it's not, the neck's not supposed to crack.
Yeah.
Do you have any digestive problems or not?
Well, ever since this, yes, I've noticed that when I lay down at night, a certain position with my pillow, I get a lot of like
Okay.
weird like stuff in my tummy, like in the upper part of my digestive system. It'll uh like a heartbeat sort of. I never had that before. And I will frequently use the bathroom more than I ever have before.
Okay.
Yes.
Then you have head pressure or not?
Pressure, no. I mean, when I go
No
to
head pressure, no head pressure, no migraine,
bed, no,
no
my
blurry vision.
no,
Okay.
nothing.
So they haven't done any scans of your neck, like they haven't done any scans?
They did a CT from here, my esophagus down to my chest cavity.
Okay, and that was okay?
It all came out very good, yes.
Okay. One of the things people can always do is do a CT venogram. Because again, like if we want to determine, like, the recurrent laryngeal nerve is a branch of the vagus nerve. So normally the dysphonia cases I see or the dysarthria cases that I see, they almost always, and then, we do ultrasounds too to see like which side the paresis or the vocal cord
Yes,
is functioning good. So basically, like what I would suspect is you're gonna have jugular vein compression probably in multiple areas in your right side of your neck, which is related to a breakdown of the neck curve, which is related to instability. So you don't have neck pain, which of course people aren't like trying to look for instability because you don't have neck pain, Because even when they do the EMG, okay, it's going to show that the recurrent laryngeal nerve, it's not working on the right side. Yeah, but what do we do about it? Like, how do we get the nerve? So,
but Dr. Hauser, they claimed that when they took the CT scan, they could not see the right laryngeal nerve because it was covered by the bar that covered my broken clavicle.
Okay.
They couldn't see it.
Okay. So normally what I find is you have to lay on your right side. So you have to, when you sleep, you have
Yes,
to lay on your right side. Then during the day, 5 minutes every hour, you have to take a break and you have to lay on your right side because you have got to take the pressure off of your right recurrent laryngeal nerve. Then to do the work that you do, because you know you're on the computer, blah blah blah. You
yeah.
you know, so you basically you have to look for two, do I have a styloid? Do I have an elongated styloid on the right? So you have to look at when you had your CT scan, did it show that you have a styloid or you don't? So somebody's got to look at that. And then you may want to get a CT venogram, you know, or you come out here and then we do all of the tests that we do. So basically, you got to move. This is important. You have to move your mouse from your right side to your left side. Because if you have a styloid, it basically every time you've been looking at your right mouse, you're compressing your vagus. Like if you have an elongated styloid, so like if you went to my desk, Vicky, you'd see like people think I'm left-handed, right? Because I have a right styloid that was starting to cause me like hearing issues here and a little bit of stomach issues here. So because I have a right styloid here, it's basically this. Like this one is on the left. You could see this right here. So basically you look down or you rotate your head, this styloid bone can smash on the vagus. So the way you get your mouse on your left side for a month or something, just you got to take some breaks, 5 minutes every hour, 2 hours. Try to sleep on your right side. And then, you know, out there, you either get a CT venogram or you come out here and then we do all the tests that we do and just try to figure out why the right recurrent laryngeal nerves having issues. But do you have any questions? Normally that responds good to structural therapy. So just
How do you feel about nerve reinnervation?
like what you're saying, like a transplant or something?
Yes,
Or
the
what?
way they take a nerve and put it in the damaged nerve and hope that they regenerate.
Well, it's always like if you didn't have a structural neck problem, of course I'd say go for it. But if you got a structural neck problem, you know what I mean? Yeah, by your own admission, it does crack. So I mean, there is some looseness there. So I guess I would just say I think you got to get a structural neck eval, you know, before you're signing up. That's what people do, unfortunately. And it's not really the doctor's fault. Like the doctors who do that therapy, that's what they do. And the patient doesn't know that there may actually be, you know, a structural cause that's the solution's a lot simpler, you know?
Do you think it would be neck, not vocal cord? Or neck?
Right. It could be a neck problem causing a vocal cord problem through the recurrent laryngeal nerve.
All
That's what
right.
it sounds like anyway.
Wow. Okay. Okay. Thank
Okay,
you.
great seeing you.
Thank you.
Great. Thank you for
Wow.
volunteering. Okay, and then so I went over Jeff's, right? Okay, I went over Jeff's, and then like when we're talking about again, like we're talking about measuring the vagus nerve, this is, you know, you can look at the vagus nerve with different kind of neck motions, right? And then Gene, oh, we did Gene. Wow. Okay. Last time there was a patient, I think it was actually a spouse of one of my patients, had asked the question about multifocal motor neuropathy. So I just want to explain how I look at different diseases and figure out, is there a structural issue for it? So multifocal motor neuropathy means that this particular patient, all of a sudden, certain muscles weren't working. So you go on Google and you're like, well, what characterizes this thing? Well, it's an autoimmune disease where you get anti-GM1 antibodies. So what's a GM1 antibody? Well, GM1 is a ganglioside. So it's a ganglioside. The highest concentration of GM1 ganglioside in the body is in the brain and the spinal cord. So basically, the body's mounting an immune reaction against a ganglioside, which is a substance that's in the brain and the spinal cord. So then it's like, well, could that be from instability? Like, could it be from instability? Well, think about this, because it was about maybe like 6 months ago or something. Somebody came on with a disorder I never heard of, but it was basically they were producing antibodies against a certain part of their brain. Like there was a substance that they're producing it. And I was talking to them, and basically, think about this. You have jugular vein compression, right? The crap in the brain can't get out. Like the crap in the brain can't get out. When we're on the cell phone and we're on our electronic devices, I mean, our brains are just getting stimulated thousands of times more than in previous generations. So that means there's all this cellular activity in our brain, and there's all these metabolic waste products that the cells are making, and it can't get out. So it's got to be a mess. It's just called neuroinflammation in the brain. Neuroinflammation in the brain. So you could really easily see where all of a sudden the body starts mounting an immune reaction against itself, because there's so many cells that are destroyed in the brain because the waste products can't get out. So I would definitely say for her, you have to look for, I would start with the neck. But if she said to me, I'm telling you, my upper back, anywhere where there's a spinal cord of the brain, I would look for ligamentous instability. And if she has it, I would treat it. And what I would do is I would measure the antibodies before you start treatment, then the antibodies later. And if the antibodies way drop, because all these things are progressive disorders. If we don't get at the root cause of it, the thing's just going to get worse and worse and worse. So that's why I say if you have ligamentous joint instability, you need to get it treated. And if the ligamentous joint instability is affecting, the voice, digestion, we've already seen a few people where they're losing weight, like it's a progressive disorder. So you have to look for it. And I'll bet you some of the cases that we even reviewed, they didn't have the classic findings of instability like neck pain and clicking and popping, but they're probably going to end up still having ligamentous joint instability. Hey, I just want to thank everybody. Love you guys. I just wanted to ask too, if there's any other way that you think that we can help, because we've kicked around the idea of doing virtual kind of consults and this and that. So if you're somebody who you feel like the office here should do something more that we could help, like obviously the office here, we're set up to see inpatient, in-person people, but I understand there's a lot of people around the globe that they need our consults or need our help. And as long as these webinars are going to be helpful to you, I'll keep doing them. And if you have any other suggestions, like if you thought I talked too fast, too slow, covered too much, let me know. The next webinar is going to be June 11th from 1 to 3. Love everybody. Thank you again for attending. Thank you for all the volunteers. Thank you for all the questions. Thank you for my media team. And until I see you next time, have a great night.